Recording in progress.
All right, recording is now in progress, as you heard. We'll be going over Chapter 16, which is medical overview for tonight. As I mentioned earlier, Chapter 14 we will cover later on in the book. Chapter 15, BLS resuscitation, will be covered during boot camps, also your CPR, whenever you take your CPR class. It's BLS resuscitation. However, there will be test questions that do come off of both these chapters, those chapters previous, in the upcoming test. So there'll be some questions from there. So still expect you to read through them, look through them, get some information off of them, because it would be good to do so. Plus that, and some of the questions from Shock, most definitely, were right in line with what we've been covering thus far. As far as patient assessments and things like that. So it lines up pretty well. That's going to come in handy in about a week or two. And if you're anything like me, that whole thing will disappear by then. It'll be out of my head. All right. So National EMS Education Standards and Competencies. It took me a little bit, too, to catch it out of the book. Speaking of Leanne, because I was looking at it and I said, hey, the schedule doesn't look right. And so I called who coordinated the class, and I said, hey, the schedule doesn't look right. Well, what's up? And I said, why is Shock not in the correct place? Or why is Shock not in here? And the person who coordinated the class said, it needs to be in there. And I was like, well, it's kind of not on the syllabus. So I found a good place to put it, which is later on, to keep us on schedule. All right. So just a short intro. Here, gotcha. So just a short intro on medical overview. Patients who need EMS assistance generally have experienced a medical emergency, a trauma emergency, or both types of emergencies, right? So trauma emergencies involve injuries that resulting from physical forces applied to the body. Medical emergencies involve illnesses or conditions caused by diseases, right? So patients can have a combination of medical and trauma conditions affecting their health as well. So you can have both. All right, so types of medical emergencies that there are would be respiratory emergencies occur when patients have trouble breathing or when the amount of oxygen supplied to the tissues is inadequate, right? And then diseases that can lead to respiratory emergencies include asthma, emphysema, and chronic bronchitis can actually occur. Cardiovascular emergencies are caused by conditions affecting the circulatory system. Some common examples of that are going to be like your myocardial infarctions and heart failure. So neurologic emergencies, they involve the brain. So they may be caused by a seizure, a stroke, or fainting. Or what do we call fainting? What is the medical term for fainting? Does anybody remember? Because you don't really want to write fainting on, there you go, syncope. That's right, syncope. So, or a syncopal episode. That's what you would put in your documentation. Syncopal episode or syncope. Gastrointestinal emergencies include appendicitis, diverticulitis, and pancreatitis. A urologic emergency can involve kidney stones. The most common endocrine emergencies are caused by complications of diabetes mellitus. What's next? We got up there hematologic or blood-related emergencies. It may be the result of sickle cell disease or other types of various blood clotting disorders like hemophilia. Then you also have immunologic emergencies. You have immunologic emergencies, which involves the body's response to foreign substances. Allergic reactions are a type of immunologic disease or immunologic condition, and it results from the body's overreaction to a foreign substance. They can range from fairly minor conditions to life-threatening anaphylaxis. So fairly minor being like on your hypersensitive or on your sensitivities, all the way up to anaphylaxis. Immunologic, toxicologic emergencies. That includes poisoning, substance abuse, and that can result in other types of emergencies. Psychological and behavioral emergencies may be specifically difficult to manage because patients often do not present typical signs and symptoms. Right? And then you also have gynecologic emergencies. So it will most likely be challenging for you because there's little you can do to treat patients in the pre-hospital setting. So patient assessment, which we've been pounding on, right? The assessment of a medical patient is similar to the assessment of a trauma patient. That's why when I said when we had the patient assessments, I was like, just grab one of them. Doesn't matter. Medical or trauma. Grab one of them. There's not many big differences, and we can work our way through them. But it's also going to be helpful to remember. Some medical patient assessments, they focus on the nature of the illness, symptoms, and the patient's chief complaint, right? And information received from dispatch can be helpful in anticipating what you might find when you arrive on the scene, but it may not be what you might find. A traumatic emergency can be a medical emergency or vice versa also, like we talked about earlier. You can have both. What you don't want to get is tunnel vision, because that could cause you to miss important injury or illness. We talked about that, right? Got tunnel vision on that scene of that motor vehicle accident, that rollover, and the young man, because I didn't expose the patient, the young man ended up having a junctional injury that I never caught. So that I didn't catch, and I caught it, but it was a little later. He was fine, that I know of. All right, so starting off, I'm already pounding the desk. Starting off, your scene size up. You got to ensure that the scene is safe. You got to follow whatever standard protocol that you have when you respond to an emergency. And then after you determine the number of patients needing assistance and consider whether you need additional help, after that you determine the NOI, or the nature of illness. Evaluation of the nature of illness for a medical patient will provide you with an index of suspicion of what could be your policy or your possibilities. The index of suspicion is that would be your awareness or your concern for a potentially serious underlying and unseen injury or illness. So your suspicion. All right, so your primary survey is going to come up next. And what you're going to wind up doing is you're going to form a general impression. So keep in mind that conditions of many medical patients may not appear serious at first. And you need to determine at this point also what the patient's level of consciousness is, or use the AVPU scale. Once you do this, you're gonna right after you do this, you're gonna identify life threats by quickly assessing the patient's airway, breathing, circulation, disability, and exposure. ABCDEs. Do it quickly. So in responsive patients, you're going to ensure the airway is open and breathing is adequate, right? You may want to consider at this point, if it's not open or adequate, you may need to fix it, right? So you may want to consider applying oxygen if breathing has been affected right then. So if you're checking SpO2 and it's a little low or what have you, you may want to go ahead and put oxygen on there. So most of the time you're being called because the illness or injury is pretty bad, right? So it's not one of those things that's going to go away. If you can mitigate it right there, mitigate it right there. As far as life-threatening injury or illnesses. Unresponsive patients may need an airway adjunct and ventilatory assistance with a BVM. So don't forget that. Always remember, keep those adjuncts and that BVM close together. All right, so you're gonna up next. You're gonna quickly assess for circulation, checking the radial. You're gonna check radial responsive. Sorry, you're gonna check radial pulses in a responsive patient, and then check a carotid pulse in an unresponsive patient. And then also, so what I generally do is on my responsive patients, I'll walk up and I grab both. I talk to them first, introduce myself, and then ask for permission. Do you mind if I take a look at you? Do you mind if I do an assessment? And then they'll say yes or get the hell away from me, and you decide what you're gonna do. So what I generally do after that is I do a pulse check on both wrists, and I do it on both wrists to feel for differences, if there's any type of difference between the both of them. So also, you're going to be observing the patient's skin color, temperature, and condition. And then what you're also going to do is you're going to quickly glance around the patient to identify any other possible life threats, such as severe bleeding or injury to the chest or something like that. I'm going to have to make a cup of coffee on our first 10-minute break, huh? Patients who should be considered serious or in a serious condition and in need of rapid transport, it's going to include your patients who are unresponsive or have an altered mental status, or AMS. Also, your patients with airway or breathing problems. And then patients with obvious circulation problems such as severe bleeding or signs of shock. That guy looks super thrilled to be there. He's like, why is all these people in here? And why is your hair so curly? The paramedic on the right. She's got some curly hair. So, history taking. That's where you're going to investigate the chief complaint. History taking may be the only way to determine what the problem is or what may be causing the problem also. This may include both a history of present illness and a medical history. You're going to investigate the nature of illness by asking questions about the chief complaint, right? And by doing so, you're going to be doing this by obtaining what history? What history will we obtain? Sample. That's right. Good job, Mr. Wade. All right, so continuing with the history taking, we're going to ask questions about the history of the present illness, and what mnemonic do we use when we're taking history of present illness? What mnemonic is it? Not sample, but what? Had a stroke there for a second. OPQRSR. That's right. That's right, Miss Church. Got a OPQRST. That is correct. So, after we obtain our OPQRST, we're going to ask follow-up questions. We try to leave them as open-ended questions, right? So we're going to ask questions that aren't just going to give us or yield a yes or a no. We're going to leave open-ended questions. So you're going to record any allergies, medical conditions, medications that the patient takes. Ask if the patients are in compliant with their drug regimen also. Look around the scene for evidence that may help you determine their history of the patient. If the patient is unresponsive, try to obtain as much of the patient's medical history as possible from other family members, friends, bystanders, or from the scene itself. All right, up next is going to be your secondary assessment. So this is designed to identify any signs and symptoms of illness or injury that were not found during the primary survey. So secondary assessment may occur on the scene or en route to the emergency department. If the patient is critically ill or injured or the transport time is short, you may not have time to conduct a secondary assessment. You may just roll on in and stay on primary assessment the entire time. Responsive medical patients, they may not need a full body exam, but perform a limited or a focused assessment based on their chief complaint. That's going to help your time out, and it's going to help you stay on track. So obtain a baseline set of vital signs because that's your trending, right? That's where you begin your trending, your baseline. So you're going to consider the automatic blood pressure cuff for future assessment at regular intervals after obtaining a manual reading. So let's repeat that. It's very important. All right? Consider using the automatic blood pressure cuff for future assessments at regular intervals only after obtaining a manual reading. I can't tell you how many times you go into a room and someone says, yeah. Someone comes in and they automatically plug them up to that auto cuff, plug them up to that defibrillator or to that monitor, and go with the hit that NIBP button. That is ridiculous, guys and girls, women and men. That is ridiculous. So you have to get a manual first. Obtain the manual first. That is a machine, and it is a machine that is built and a lot of times purchased by as the lowest bidder. So we need to make sure that we take a manual and then we use the auto cuff to back up what we're saying or to to kind of supplement what we said or what we got. Depending on your local protocol, you want to consider also obtaining a blood glucose level and pulse oximetry reading. So every AMS patient, if a patient is altered in any shape, form, or fashion, SpO2 and blood glucose, those will be in there, along with your pulse rate, respiratory rate, BP, all that. But AMS, you have to add to that SpO2 and that CBG, as well as a good one to add in also is what else? The gold standard, right? Capnography. Should every patient with syncope get an EKG? Yes, they should. Because we don't know what caused the syncopal episode. Any chest pain, anything like that as well should get an EKG. What about an ECG? No, not one of those. An EEG. They got one for everything. Now, here's a good one too, and I'm a big fan of this, even outside of these realms. For patients sick, they should get this. End-tidal carbon dioxide monitoring. It should be considered if the patient complains, especially if the patient complains of respiratory problems or is suspect of a stroke, like I'm talking like today. So any patient who's in cardiac-related symptoms should be placed on a cardiac monitor. Any patient. Syncopal episode can be considered that as well because we don't know why they went out. All right, up next is going to be the reassessment. Once the assessment and treatment have been completed, a reassessment should begin and it should continue throughout the rest of the transport, right? Yep. Absolutely. And then you're going to repeat the primary survey and reassess the chief complaint every time. You're starting it over. The process starts over. You look for any changes in the level of consciousness. You reassess the patient's vital signs. You re-examine the transport decision. And then you're going to reconsider the need for paramedic backup if you called it. Hold on, Leanne. I'm reading yours. It's going to... went back to where Leanne had a possible stroke patient. Yep, it happens. And another thing is like if you don't, I love taking manuals, but I like the monitor for confirmation. I use the monitor for confirmation, and I use the monitor if it's accurate from what I got, then it's helpful, and it's helpful in a lot of other ways too. And you got to have all of it in order to get a full picture. That's why I don't quite understand. I know what I've been told, but I don't understand why AEMTs don't do 12 leads. And sometimes EMTs, for that matter. Why they can't do 12 leads. Because the more information you have available to you, the better. And it doesn't take that much time. You should have a 12 lead on that person, depending on what their symptoms are, within 60 seconds of arrival to the patient. Yet, go ahead.
In Mississippi, you're allowed to transmit one to the hospital.
Yeah.
But you can't interpret.
What good does that do you? What, other than the fact
that to talk to a doctor, and the doctor's supposed to relay it back to you, but you know as well as I do how much they communicate.
Yeah, exactly. And I can tell you this as well, is that I've come in with strips before, and I've handed it to a doctor, and him literally look at me and go like, I don't know, that's not my job. It looks squiggly. So, I mean, you don't know who you're going to get. I think it's good that you know how to do it. I think it's good that you know how to interpret. Now, for National Registry purposes, AMTs do not do that. They don't do it. I know in the state of Mississippi what they do, but I know in National Registry wise they do not. So they don't mess with that kind of deal, the whole 12 lead deal. I think it's a good class to take, and it'll help you understand a lot more if you have it. There are some very good teachers out there that can do 12 leads and 4 leads. AMR used to put on a pretty awesome 4 lead and 12 lead class. AMR did. Joel Elsey. He used to put on a darn good one. All right, so also you need to, while you're doing all this, document any of the changes that develop as a result of the treatment that you gave, and if needed, adjust any of your treatments while you're on the way, and alert the ED before arrival of potentially critical patients as well. Let them know. I'll have to look. I want to say it's 4 lead. It's going to be 4 lead anyway, I would assume. So, management, transportation, and destination. So most medical emergencies require a level of treatment beyond that level in the pre-hospital setting, right? So the patient may require advanced testing available at the hospital. The primary pre-hospital treatments address the symptoms more than the actual disease process. So administration of medications that are stored in the ambulance is limited for AEMTs, right? Any administration of medication by an AMT requires direct permission from medical control. Is that clear? Any medication by an AMT requires direct permission from medical control. Written protocols may allow the administration of certain medications without calling for online medical control. What do we call that? Anybody know what we call that? Offline. That's right. You're going to complete a thorough assessment of the patient before calling medical control for permission anyway, right? You want to make sure that you do that. Because they will ask you questions. And you don't want to be sitting there going, hold on, let me check. Depending on what. Now, if it's out there, then that's fine. AEMTs can use the AED or the automatic external defibrillator on a patient who is pulseless and apneic. In some cases of cardiac arrest, immediate treatment with an AED may provide the best option to resuscitate that patient. So if you come up and you're in that situation, go ahead and slap it on there. Do it quickly. And no, the sticky pads do not work any longer for tearing hair off. And you're wasting a pad when you do that. And that may be the last one you got on the truck, depending on what company you work for. So use the razor that's in there if you have to. Dry the patient. Use the razor. I've seen old school medics grab that pad, slap it on a patient's chest, and then rip it off, and the hair still be there. And it's like you don't do that anymore. That doesn't work like that anymore. You may get a little bit of hair. It ain't going to be enough though to fix anything. All right, so scene time. The scene time may be longer for medical patients than your trauma patients because that stay and play factor, right? You're having to figure things out a little more. You're going to gather as much information as you can from the scene to transmit to the emergency department anyway. because there's going to be pills there and everything else, the environment and all that good stuff. So you want to make sure that you have good documentation of that or something you can pass on. So some critical patients that always need rapid transport are going to include your AMS patients or altered mental status, your airway breathing difficulties, your circulatory compromise, very old or very young. All right, get them on the road. Give them diesel or electric. Give them sun. I guess you would say give them sun for the electric cars. Type of transport. If a life-threatening condition exists, the transportation should include lights and sirens. Code 3 is what we call it around here. If you call it anywhere else, getting you under. If the patient's not critical, then consider a non-emergency transport. So it doesn't always have to be lights and sirens, unless of course you work in a system status management ambulance system where everything under the sun is lights and sirens. And then it doesn't matter what you're doing. You could be in the middle of a cardiac arrest, coding a patient, and somebody come on the radio. Can you please 1017? Can you please 1017? We have system status management. We have calls waiting. Ty knows. Ty knows who I'm talking about. Once again, that's why I was a fire medic. That's why I went back to fire medicing instead of. That's why I went back to fire medicing instead of riding on the ambulance anymore. Oh, I like sleeping. I'm kidding. No, I do though. I agree. You should. Hey, and keep on the lookout. Keep on the lookout. They may start paying a little higher in the near future. So keep up with your stuff. Make better friends. Build some rapport, Mr. Walker. Modes of transportation, ultimately they come in. Modes of transportation, ultimately it comes in one or two categories, ground or air, right? Ground transport EMS is generally staffed by ALS support, so like your AEMTs or paramedics, and then also EMTs. Now, when you pass the test and everything, you'll be able to go, ALS, AEMTs, paramedics, and then, we got this other guy that's in the truck with us. You'll be able to do stuff like that. It sounds so cool. Air transportation EMS or critical care transport are generally staffed by critical care nurses and critical care paramedics. A lot of times. I think the critical care paramedic is a good study and test to take, and to do that anyway. And that's going to help you in a number of situations at CCP. And flying's fun too. I did it for the Air Force and loved every minute of it. Best job in the Air Force is flying. I would take flying air vac again over firefighting, and that's saying something because I love the fire service. But I would take that job back again before I took my most fun moments in my other jobs or in my other fire jobs. That's saying something. I'm telling you, you get off the air and you get off the ground and you start working on patients. It's a whole new world, and you won't turn back. You won't want to turn back. What will make you turn back is the company. The people you work for, management, will always make you turn back. But the job itself, best job in the world. Best job in the world. I have not met a single person that has disagreed with me. Unless, of course, you're Mr. Martinez. He's probably HRT or something like that. So, management, transportation, and destination. Generally, the closest hospital with an emergency department should be your destination, right? At times, the patient will benefit from going to another hospital that is capable of handling his or her condition. If the patient experiences cardiac arrest during the transport, immediately reroute to the closest hospital with emergency facilities. You always want to make sure to do that. Contact med control if you're unsure. And then some patients may actually benefit on-scene treatment provided by paramedics also. So faster treatment, quicker treatment, more having more efficient care. Okay, so that's why it's good too, is to understand. Every shift we used to get a sheet from the ambulance company saying which hospitals had what type of availability for what type of what they could handle. Okay, if they could handle neuro today, or if they could handle cardiac today, or whatever. So we had those. We had those sheets, and it told us that. It told us who was on saturation, who was on diversion, so on and so forth. It's good to have those sheets. A lot of times, this is what I saw. Somebody would take that sheet from their supervisor, and then they would go into the truck, and where does it go? Right on the dashboard. They throw it right on the dashboard. Wouldn't even look at it. And then just think they know what's going on. Especially nowadays, with the way that everything is now with COVID, you gotta take a look at it. You gotta know who's on diversion, who's on saturation, and you gotta know who you're gonna take your patient to. Sometimes you can tell that patient, and that could also help you out too, because you could tell that patient, hey, they're not going to be able to do this because today you have the stroke patient. Stroke patient telling you that they want to go to Keesler, or they want to go to this level 4 hospital, this roll Band-Aid station, roll 3 or roll 4 hospital. And they come up, it's a stroke patient, you believe it is, and they're like, I want to go here. I want to go to Sunnyside, I'm making that up, the hospital. I want to go to Sunnyside Hospital. Well, I'm sorry, but they don't have neuro on duty today. I want to go there. That's where my doctor is. Well, they don't have neuro on duty today. They're not going to be able to help you. And so it's good to be able to argue that down. But like, you will not have a good outcome if we go to Sunnyside, because Sunnyside doesn't have neuro on duty today or available today. And they also don't have a snack station for EMS, so we definitely ain't going there, and it's close to lunchtime, and I ain't got to stop yet. That's another one. Garden Park used to be so good at that. They used to have the whole snack station and everything else. They were real winners. And then it went away. I forget that some of y'all aren't from around here. Infectious diseases. So, an infectious disease is a medical condition caused by the growth or spread of harmful organisms within your body. A communicable disease is a disease that can be spread from one person or species to another, right? Communicable. Some general assessment principles for that. You're going to approach the patient with an infectious disease like you would any other medical patient. You're going to size up the scene, and you're going to take standard precautions. That's why I always say your PPE, that matters. Knowing if you do know that they have an infectious disease, be prepared for that. All right, so you're going to perform your primary survey and your history taken just like anything else. Typical chief complaints are going to include things like fever, nausea, rash, pleuritic chest pain, and difficulty breathing. A lot of times we hear chest pain, pleuritic chest pain. You'll know if they breathe in and out. That's why we ask, does anything make it better or worse? If touching it makes it worse, or when they breathe in and out makes it worse, you may not be looking at a cardiac issue, chest pain. So some general management principles for this infectious diseases. You're going to focus on any life-threatening conditions identified in the primary survey first, right? Be empathetic towards the patient. And then place the patient in a position of comfort on the stretcher to keep warm. So blankets, things like that to help them out, to keep them warm. Position of comfort to help breathing or help assist with breathing or pain or what have you. Make sure you follow your standard precautions. Always follow your agency's exposure control plan in cleaning your equipment and properly discard of any disposable supplies, as well as linens also. Here's something I see quite often. So, how many people have worked in a ambulance setting in here? I don't see it. I didn't see it near as much in the hospital. I've seen instances where a paramedic will go to give a flush, or a paramedic or a EMT will put together a pigtail and hand to the medic, and the medic be like, "No, I don't need that just yet," and set it off to the side. Save it for the next patient. All right. What do you think of that? Hand you a pigtail, you don't need it, so you grab this pigtail, and then you're like, "Nope, don't need it," and you set it, and you're like, "I'll give that to the next patient." Do you think that practice is okay? No, it's not okay. Why is it not okay, Miss Hughes? It's contaminated. It was in a package for a damn reason. And now you broke it out of the package. It was meant for that patient. If it's not going to be on that patient, it gets choked. That gets chunked. Gets chunked. It happens all the time. Don't do it. Don't be the reason why your patient gets sick with what we call, when you get sick from a hospital type infection or any type of hospital, whether it be pre-hospital or in the hospital, what do we call that infection? Does anybody remember from EMT? When you catch an infection from inside a hospital or inside an ambulance, what do we call that? Because of some sort of medical treatment. A lot of times, this is used when we talk about pneumonia. When you get pneumonia from the hospital. Yep, same difference. Same exact difference, Miss Hughes. That's right. So what they call that is a nosocomial infection. Does anybody remember that term? Nosocomial infection? So it gets nosocomial infections are like whenever you're in a hospital and you wind up with staph, something like that. You're in a hospital and you wind up with C. diff, like you're a patient. You wind up with C. diff. Yeah. Or you wind up, or because you have an intubated patient, or you have a patient that's been on oxygen or not so much on BiPAP, but and they wind up with they've been on a vent or what have you, they end up with pneumonia, or you're in the hospital, or you've had these chest issues and everything else, and you wind up with pneumonia because you haven't been getting your proper breathing exercises and things like that. Yep, that's right. Sure enough, nosocomial infection happens all the time. What can you do about that? Proper standard precautions, clean your damn hands, clean your equipment, things like that. Make sure you're not, opening up stuff and then saving it for the next patient, stuff like that. Mainly it's cleanliness, it's hygiene. So if you work in a hospital, you could probably tell it better than me. You know, they say they used to use this term all the time: gel in, gel out. So gel in, gel out. Gel in, gel out being the spray pump, the hand sanitizer, and so people would go hand sanitize up. Yep, I'm good to go, and then they would go into the next patient. Well, that works to a certain extent, but also one thing it does, it kills all the good bacteria that are on your hands that keeps your hands healthy, but also and it cracks up your hands and everything else. But after a while of doing that, then you're only gelling in what? You're only gelling in this. You're not looking at any of this. You're not paying attention to any of this or anything else you're working on. You're not doing your hands any good, or you're not washing your hands before every patient. Technically, in an ambulance, you should do things like cleaning. After you mess with a patient, when you drop the patient off at the hospital, go into the wash station, wash your hands off. Wash up. Wash that damn pin, or get another pin, or whatever. Put the gel on the pin. But there's a lot of things that we do that transfers germs from one patient, germs or viruses or what have you, from infectious diseases from one patient to another. And it's just because normal everyday business, we become what's called complacent. We get a sense of complacency. Actually, that's a nonsense of complacency. That's a nonsense. So you become complacent and then something happens. Complacency kills. Remember that. You're not doing it for you, you're doing it for your patients. So this is what we're in right now, epidemic or pandemic considerations. So an epidemic occurs when new cases of disease in a human population substantially exceed the number of expected based on recent experience. A pandemic is an outbreak that occurs on a global scale. Pans across the world. All right, before we start off on this, we are going to take a 10-minute break. Sound like a winner? Sounds like a winner. Winner, winner, chicken dinner. Nope. All right, 10 minutes, or 9 minutes and 50 seconds. Took a little longer to make my coffee than I anticipated. What can you do for a snake bit dog besides Benadryl? I don't know. Snake bit by what? What type of snake? I'm sorry I missed that. You don't know? Is it swole up? It might be. Might have been. So it depends on if the snake envenomated, then it needs some sort of antivenom if you want to pay that much. Other than that, though, something for the something for the pain possibly, or Benadryl's good for. It's not good for infection. It's good for an allergic reaction, but it's not good for infection. So you'd have to get some sort of antibiotic. Definitely have to load them up with antibiotics just to make sure. But a lot of snakes don't envenomate. They'll bite, and then you can catch some sort of bacterial infection from that. But antibiotics are usually pretty good. Yeah, wheezing's probably not good. Probably needs to go to the animal ER. Did it bite him on the face? I'm gonna go with animal ER. Because if he's starting to wheeze, then just like in a human, that can lead to other problems. All right. There we go. All right, HIV infection and AIDS. Common or serious communicable diseases is what this is going to be under. So, the human immunodeficiency virus infection and acquired immunodeficiency syndrome, HIV and AIDS. It was first identified in the late 1970s. According to the U.S. Centers of Disease Control and Prevention, more than 1.2 million people in the United States are infected with the virus currently. 1.2 million. Okay? Gay and bisexual men, particularly young African American gay and bisexual men, account for the majority of those new diagnoses. And then HIV infection is a potential hazard only when deposited on a mucous membrane or directly into the bloodstream. Mucous membrane and bloodstreams. It could, very well could. Um, don't they have to report that to whom? So, no, it doesn't have to be reported, no. It's a courtesy more than anything. Now, they do have something called the Ryan White Act that can give you some coverage as far as that goes. But here's the thing: you're gonna run across patients that have they're gonna have HIV/AIDS. They're gonna have Hep C and all that good stuff. You're never gonna know, and that's why you use standard precautions. That's why you use proper technique in order to do your business, because you're not going to treat that patient any differently no matter what they have. You can't. You're not going to treat that patient any differently. Um, I went to a class one time, and we had a new student that made the effect said, "Hey, what if I get an AIDS patient? Do I have to give that person an IV?" And the instructor said, "No, you don't have to give that person an IV once, because after that you won't be in this business anymore. That's just that's part of the job." So no, because of the Ryan White Act, if you have an exposure or anything like that, you can get that information. But does somebody have to come right out and tell you, "Hey, I have AIDS"? No, no, they don't. They do not. Now, if they spit in your face or anything like that, then it becomes a criminal, some sort of criminal ordeal at that point. So I'm much more worried about Hep C than I would be AIDS anyway. Uh, so along with it's primarily so AIDS is primarily a sexually transmitted disease, but it's also a bloodborne disease. Okay, it can be transmitted from a pregnant woman to her infant in the birthing process as well. Um, HIV is also transmitted through blood transfusions at times. So, in a person with HIV infection, the entire immune system begins to fail, right? And it allows life threatening, opportunistic infections to flourish. And that's why that happens. Immunodeficiency, right? HIV pathogen, it envelops infected cells and it attacks the immune system and other body organs. Okay? And many patients with a human immunovirus show no symptoms at all. So they themselves may not even know that they have it. So some signs and symptoms may include all that you see here. So acute febrile illness, febrile being fever, right? Malaise, fatigue, sore throat, swollen spleen and lymph glands, headache, weight loss, and possibly a rash. So, acquired immunodeficiency syndrome is the end stage disease caused by HIV infection. A patient with AIDS is extremely vulnerable to numerous bacterial, viral, and fungal infections that would not affect a person with an intact immune system, right? And then pre-hospital management of HIV or AIDS is supportive for AEMTs and for just about anybody. It's supportive measures. No vaccine it exists for it at this point. So despite the great process we've made in drug cheat treatments and vaccines, AIDS is still very, very fatal. Unless you're a conspiracy theorist, then you know that there's a vaccine out there somewhere. It's not easily transmitted in the EMS setting, so it's far less contagious than, say, Hep B even. Okay, your risk of infection is limited to exposure to an infected patient's blood and bodily fluids. So, how do you help that? Standard precautions, right? Infectious disease control. Because many of the patients who are infected with HIV don't show any symptoms, you're always going to take precautions to prevent infection, including wearing things like some things that you'll wear as far as your PPE are going to be your proper type of gloves, proper size of gloves. You're going to take care in handling and disposing of needles and scalpels. You're going to cover any open wounds that you have whenever you're on the job. And you're going to practice good hand washing technique and routines in the ambulance and cleanup after transports. All right, if you have any reason to think that a patient's blood or secretions have entered your system, you got to seek medical advice as soon as possible. Take your exposure do your exposure protocols and get it figured. I've actually had this happen to me in exposure. Had an exposure of Hep C years and years ago, and I didn't find out about it until a couple of days after I had handled the patient. I got a phone call from somebody that said, "Hey, I just want to let you know that this patient that you were covered in blood in had Hep C," which I remember this patient like it was 2 minutes ago. I pretty well knew he probably did have Hep C at the time. So, I had taken precautions, and after I got out of the ambulance and everything. What is that? Is that me? That was funny. That was too funny. That was so funny. All right, that's scary. That kind of scared me for a minute. So this patient. So I went anyway. Anyway, make a long story short, they called me up, told me this. I immediately had to start my exposure protocols, which I had already started anyway about the blood getting all over me and everything else. But I had to come in for a baseline test to see if I had Hep C, see if I had any diseases. And then I had to wait 21 days for the results, and at which point I had to go in and take another test. So 21 days I had to wait before I could take another test. Because the incubation period, it's not going to show up right away. But I had to wait 21 days before I could take one. So you could just imagine, how tense things are, and you're scared. You don't know what's going on or anything else. So yeah. Yep. Yeah, it did. I mean, I remember that when I got out of the ambulance, I stripped completely down. We were in the fire department parking lot because we were meeting the helicopter. So I stripped completely down on my way inside and threw everything in a red bag, and then immediately got in the shower and cleaned off, cleaned up and everything else. So I mean, I took very strong precautions against whatever happening. I wore goggles. I was actually wearing goggles at the time, and gloves. I didn't have a gown. I didn't have any open wounds that I know of. But yeah, so it was one of those things like I did the right thing, but still, yet you still in the back of your mind wonder, what if I didn't? All right, so influenza. So commonly known as the flu, right? Everybody's well aware of influenza. It's primarily an animal respiratory disease that has mutated to infect humans. Gee whiz, little thing there, right? Those with chronic medical conditions or compromised immune systems, the very young and the very old, are particularly susceptible to influenza. So the ways that are transmitted by direct contact with nasal secretions, aerosolized droplets from coughing, sneezing by infected people as well. Then you have the H1N1 virus. It was initially identified as the swine flu in 2009, H1N1. It's a specific form of influenza, okay? General treatment includes supportive treatments, all right? So fighting off the symptoms, what have you. So influenza and other potentially serious diseases can be passed by a respiratory route. So that's why it's important to wear your personal protective equipment, your frequent hand washing is important. Maintain your vaccinations, and then place a surgical mask on your patient that has any type of respiratory disease. Okay. Also, wearing a HEPA respirator during any aerosol generated procedures being like, what would be an example of an aerosol generating procedure? Can anybody tell me a few? Just think of something that would probably create aerosol. MDIs, yep. What else do you think? Nebulizer. Awesome. And then there's another big one that we use for respiratory distress. Also. CPAP, right? CPAP. Awesome. Good job, fellers. So those are aerosolizing procedures. That's a big deal when we're doing COVID, when we're dealing with COVID, is those type of procedures. Down to resuscitative efforts could be aerosolizing, okay? Or like BVM, stuff like that. Okay, open mouth, pressing, yep. So up next, we'll talk about hepatitis. It's inflammation and often infection of the liver. Can be caused by a number of different viruses and toxins. Complications of hepatitis include scarring of the liver, liver cancer, and liver failure. So according to the CDC, hepatitis C accounted for the highest mortality rate in the United States in 2014 of the three types of viral hepatitis. That's why I say I'm way more worried about hepatitis C than I am the other types of hepatitis or AIDS or anything like that. Depending on severity, patients with hepatitis, they may be asymptomatic or may have a variety of signs and symptoms. Some early signs of this could be loss of appetite, nausea and vomiting. Hold on. All right, so some early signs going back would be like a loss of appetite, nausea and vomiting, fever, fatigue, sore throat, cough, muscle and joint pain. Well, all look like signs of what? Like flu, right? Flu-like symptoms. So several weeks later, jaundice or yellow eyes and skin and upper quadrant abdominal pain develop. So why do you think that you would become yellow? You would become jaundiced. Why do you think that is? Automatically, when you see a jaundiced patient, what do you think is happening? Some sort of liver malfunction, right? That's right, liver failure. That's correct. So management of patients with any type of hepatitis is strictly supportive. There is no sure way to tell which hepatitis patients are contagious. Toxin-induced hepatitis is not contagious, for example. A carrier is a person or an animal, possibly, in whom an infectious organism has taken up permanent residence and may or may not cause an active disease, right? Carriers may never know that they harbor the organism that can infect others. Hepatitis A is transmitted orally through oral or fecal contamination. Another issue. Organisms that cause hepatitis B, C, and G, hepatitis G even, are transmitted through vehicles other than food or water. Okay, the virulence of different types of viruses, diseases, the virulence or of viruses, or the ability of the pathogen to produce disease. Virulence, that's called it's the strength or ability of a pathogen to produce disease. So hepatitis B is far more contagious than HIV. It has high virulence, right? Vaccination with hepatitis B vaccine is highly recommended for AEMTs, for any medical worker. Not everyone who is vaccinated develops immediate immunity to the virus. So you have to seek testing after vaccination to determine your immune status. Here we go, Ty. All right, so herpes simplex. It's a common virus strain carried by humans. More than 85% of people carrying the virus are asymptomatic. Symptomatic infections cause eruptions of tiny fluid-filled blisters called vesicles that often appear on the lips or the genitalia. Herpes simplex can cause serious illness like pneumonia and meningitis in the very young and very old and immunocompromised patients as well. The primary mode of infection for herpes simplex is through close personal contact. So standard precautions are generally sufficient to prevent the spread or to or from healthcare workers. Syphilis. So, although syphilis is commonly thought of a sexually transmitted disease, it's also a blood-borne disease. There's a small risk of transmission through contaminated of needle stick injuries or direct blood-to-blood contact. The initial infection with syphilis produces a lesion called what was that called? A chancre? A chancre? I think that's how it's pronounced. I don't know. I can't remember. Canker. Good lord. It just popped in my head. Yeah. I was looking at it and I was like, I was thinking of, but as soon as I looked at it, I was like, Shanker. They don't even make sense. Canker. That was silly of me. Cankers are most commonly located in the genitalia region. Thanks, Leanne. had brain flatulence for a minute there. So, meningitis is inflammation of the meningeal coverings of the brain and the spinal cord. Some signs and symptoms of meningitis are going to include fever, headache, stiff neck, or altered mental status, altered mental status. Chancery. I'm going to have to tell my wife that. She's going to laugh at me. So, vaccines are rarely used for meningitis. Also, meningitis can be treated at the emergency department with antibiotics. After treating a patient with meningitis, you have to contact your employer health representative. So make sure you do that. In many states, meningitis is reportable. In such states, you may be contacted if one of the patients you handle is diagnosed with meningitis. It's a big deal. All right, up next is TB. So a chronic mycobacterial disease that usually strikes the lungs. Many infected patients are well most of the time. If the disease involves the brain or the kidneys, the patient is only slightly contagious. Okay. Disease that occurs shortly after infection is called primary tuberculosis. Reactive tuberculosis is common and can be much more difficult to treat, especially because an increasing number of tuberculosis strains have grown resistant to most antibiotics. Patients who pose the highest risk almost always have a cough. Consider respiratory tuberculosis to be the only contagious form because it's the only one that is spread by airborne transmission. Droplets produced by coughing are not the real problem, but rather the droplet nuclei is the problem. And droplet nuclei are the remnants of the droplets after the excess water has evaporated. Okay? So N95 or HEPA masks are required to prevent the inhalation of droplet nuclei. For a patient with dyspnea, wearing a non-rebreathing mask oxygenates the patient while preventing the droplets from spreading to the AEMTs. If the patient is not having difficulty breathing, place a surgical mask on the patient and a HEPA mask on yourself while you're working with the patient, right? It's a good idea. So, absolute protection from infection with the tubercle bacillus or bacillus, it doesn't exist. So TB, the absolute protection from the infection TB, it doesn't exist at all. Everyone who breathes is at risk for it. According to the CDC, 1/3 of the world's population is infected with TB at any time. The vaccine for TB, also called Bacillus calmette-guerin, so it's only rarely used in the United States. Also, the mechanism of transmission used by M. tuberculosis is not very efficient at all. So what we usually do is we have a tuberculin skin test regularly. Remember the little intradermal? It makes a little bubble or not. You come back and they check it. So if the infection is found before you become ill with it, preventative therapy is almost 100% effective for that. All right. Up next is pertussis, which is also called the whooping cough. Whooping cough. It's an airborne disease caused by bacteria that previously affected children younger than 6 years old. It's now becoming common in adults whose vaccination was years prior and whose immunity has decreased. Symptoms include fever and a whoop sound. Whoop. When they cough. I can't even fake the sound. And it occurs when the patient tries to inhale after a coughing attack. Just the whooping sound. The best way to prevent the infection from pertussis is to be vaccinated with a diphtheria, tetanus, and a cellular pertussis or DTaP vaccine. So for added protection, you need to place a mask on the patient and on yourself. So up next is methicillin-resistant Staphylococcus aureus, or MRSA. It's a bacterium that causes infections and is resistant to most antibiotics. Nosocomial infections with MRSA are believed to be transmitted from patient to patient by unwashed hands of healthcare providers. Like we talked about, right? Nosocomial infections. Studies have shown that 1% to 5% of healthcare providers carry MRSA in their nares, in their nose. To prevent MRSA transmission, we use gloves and practice good hand washing technique. So some factors that increase the risk of MRSA are going to include antibiotic therapy, prolonged hospital stays, a stay in an intensive care unit or a burn unit, exposure to an infected patient. So incubation period for MRSA appears to be between 5 and 45 days. Quite a big spread there, right? Exposure will not occur if you're in direct contact with wound drainage, but your skin is intact. Okay? Skin is intact. No post-exposure treatment is recommended in case of true exposure, but the incident must be documented. So here's some new... Yep. I'm sure. So here's some new and emerging diseases. The hantavirus. It's rare but deadly virus transmitted through rodent and urine and droppings. Shoo. It's not transmitted from person to person directly, but by a vehicle, such as food, or a vector, such as a rodent. We also have what's called West Nile virus. Its vector is mosquitoes, and it affects humans and birds. These diseases are not communicable and pose no risk during patient care. So another one is SARS, or severe acute respiratory syndrome. It's serious potential life-threatening viral infection caused by a recently discovered family of viruses. So like SARS-CoV-2, maybe, right? SARS usually starts with flu-like symptoms, which may progress into pneumonia, respiratory failure, and in some cases, death. Transmitted by close person-to-person contact or by secretions. So SARS-CoV-2, which is COVID. Avian flu, or avian flu being the bird flu. It's caused by a virus that occurs naturally in the bird population. It's carried in the intestinal tract of wild birds and does not usually cause illness. In domestic bird populations like chickens, ducks, and turkeys, it's very contagious. If an infected bird is used for food and is cooked, it does not pose a risk to those who eat it, right? Humans can get it when they have close contact with infected birds. So no rapid human-to-human cases have been reported as of yet, and the transmission risk for humans is low also. So the global health issues: Middle East respiratory syndrome, coronavirus, or COVID. So this is something that came out, a while back. Most commonly found in bats, camels living in the Middle East. There's been cases of infections that have also been reported in Europe, United States. Symptoms are going to be high fever, cough, muscle aches, vomiting, and diarrhea. Presently, there's no cure or vaccine for that virus. If you suspect that your patient has MERS COVID or MERS CoV, you're going to place a surgical mask on him or her and notify the receiving facility. Up next, we got Ebola. I was working at an airport when the Ebola scare happened. Oh my gosh. Every plane we had with a sick person was just huge. Nah. It wasn't that scary. The thing is that a lot of these diseases become less scary. They become less scary once you realize how to protect yourself, as well as you're in the United States. If you get Ebola, you're in the United States. There's a very high chance that you could come out of it on the positive side. So Ebola. The incubation period is approximately 6 to 12 days after your exposure. Symptoms, they may not begin to appear for as long as 21 days after infection. So some of the symptoms that you could have could be watery diarrhea, vomiting, fever, body aches, and bleeding. The fatality rate can be as high as 70% if effective supportive treatment is not initiated promptly. What is the virus that was in the movie Outbreak? Is this a quiz question? Because I know who knows it. What was the virus in Outbreak? What was the virus in the movie Outbreak? Oh my gosh, everything's popping up vaccines.gov. I don't care. What was the virus in the movie Outbreak? Google knows. It was... Okay. The film focuses on an outbreak of a fictional Ebola virus and orthomyxoro or orthomyxoviraxo blah 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 Matoba or Mataba, the Mataba virus in Zeri, later in a small town in California. So the Mataba virus. Motaba. I like that movie. Actually, so that movie, Outbreak, this is the honest truth, is that when I was growing up, I could watch Jaws. I got to watch Freddy Krueger, Jason, all that stuff when I was little. That movie right there, Outbreak, scared the crap out of me because you can't get away from it. I was always movies that have characters or diseases or anything like that scare the mess out of me because you can't get away from it. So another movie that freaked me out also was The Grudge because you couldn't get away from the damn thing no matter how hard you tried. I sat in the movie theater with my feet up on the deck, or my feet were sitting up in the chair with me because I didn't want that girl grabbing my feet. Can't get away from it. I came home after watching that movie and took my TV and put it face down on the floor. Because if she's going to come out the TV, I ain't going to make it easier. I ain't going to make it easy for her. I didn't have a flat screen back then. We had box TV, so you can't break that thing. You throw it off of a building, it still worked. All right, up next, Zika virus. So the Zika virus, what was that? That one was kind of scary too. 7 days. 7 days. Crap, what was that? It was the movie I was just talking about. That was The Grudge, yes, but The Ring. The Ring was also, that was a good one too, because you couldn't get away from it. Once they called and said 7 days, that was it for you. You were dead. Didn't matter where you went. It was coming for you. And then you made this stupid face right before you died, and that's the way people found you. It's just... man. So Zika virus, it's a vector-borne infection first noted in the United States in mid-2015. So it's transmitted by the bite of the Aedes aegypti mosquito. So a certain type of mosquito. There's no vaccine for this virus. And prevention is aimed at protecting against mosquito bites. So according to the CDC, most people infected with Zika virus present with few or no symptoms, right? So symptoms of Zika virus include fever, rash, joint pain, and conjunctivitis. Okay? Other symptoms may include muscle pain or headache. Symptoms are usually mild and last for several days to a week. Zika virus can be diagnosed with a urine or a blood test. Most significant complications affect pregnant women for the Zika virus. The fetus is at risk for serious birth defects, including microcephaly. Other than mother to fetus, the most common route of human-to-human transmission is through sexual contact. The care for Zika virus is supportive. No recommendations for special protective equipment for medical personnel except to prevent person-to-person transmission through blood or bodily fluids. So travel medicine. Patients who acquire an illness from another country can present with a variety of symptoms depending on the illness. When you encounter an ill patient with a recent travel history, place a mask on that patient and gather as much information as possible from that patient. If you suspect the patient has a communicable illness, follow appropriate PPE precautions and notify the receiving facility as well. That is how pandemics get started. So important questions to ask that patient is, where did you travel recently? Did you receive any vaccinations before your trip? Were you exposed to any infectious diseases while on your trip? Is there any Is there anyone else in your travel party who is sick as well? Which type of food did you eat? What was your source of drinking water? Good things to ask. Don't drink the water. So, as you can tell, we're getting near the end of this one. In conclusion, the assessment and treatment of a medical patient can be very challenging. Medical patient's conditions may not be readily apparent as in a trauma patient. The best approach is to keep calm, use your patient assessment skills, treat the patient's symptoms while maintaining a high index of suspicion for underlying problems, report to medical control, and transport the patient safely to the closest, most appropriate facility. Keep in mind that patients sometimes have more than one isolated problem, so keep that in mind. So the best approach to this is going to be keep calm, use your patient assessment skills, treat the patient's symptoms while maintaining a high index of suspicion for underlying problems, report to medical control, transport the patient safely. Keep in mind that patients sometimes have isolated problems. Was that the same thing twice? It sure was. I was on top of that one, wasn't I? All right. So that is it for that slideshow. All right, so do we have any questions about medical overview? Any questions at all? Is there anything that anybody would like to go over? As you can see in there, I don't know if y'all saw. Oh, we'll talk about that in a minute. So if we don't have any questions, then I guess what everybody is waiting for is the magic code, the magic entry code. Hey, so I want to also make sure that everybody is still doing their attendance form. And on the ARES website. Is everybody still doing that? Y'all are very quiet. You're caught up? Good to go. Make sure you definitely put that in there. Whenever I do my attendance here, so it automatically reads that you are in the class, but your attendance is what is the very primary thing that gets turned in to NREMT or any of the powers that be that prove that you are actually in this class. Because I have to turn in all of my codes also. Are you kidding me? Why is this being like this? Okay. That I don't know. That I don't know if there's any way to go back. I would have to ask Rob if he can see those, because I can't see those. I don't know if she knows. All right, so the magic code for tonight, chapter 16, is going to be 7890. 7890. 7890. Enter. Alrighty. So that is it. 7890 is the code to get into the quiz. And I'm going to stop recording